So today we are starting with head and neck, and this is the most important part of anatomy. So first we'll be studying scalp in this topic. So what is the extent of the scalp? So we'll be starting with the extent. So scalp starts from the on the anterior side, it starts from the supraorbital margin. So this is basically the supraorbital margin. Then on the posterior side, its extent is external occipital protuberance, which is this. This is the external occipital protuberance, and the superior nuchal line. This one is the superior nuchal line. External occipital protuberance and superior nuchal line. And on the sides, we have superior temporal line. So this is basically temporal bone, and this is the superior temporal line. So this is the extent of the whole skull. Okay, then there are 5 layers in skull. First is the skin, and scalp is basically itself is an abbreviation. So first layer is the skin, second is the connective tissue, third is epicranial or galea aponeurosis with occipitofrontalis muscle. Then from L it has loose connective tissue, and from P it is pericranium. So C is the connective tissue. So these connective tissue are very dense kind of connective tissue, and these 3 layers SCA, these are very tightly adherent to each other, right? So this is the diagram. So here the layer of connective tissue is divided into various septas, and each septas are having its own blood vessels and nerve supply, right? And this is the brain cord covered with the pyometer. So this is pericranium, this is arachnoid, this is pyometer. Okay. Then we have skin. So we are now studying the layers of the scalp in detail. So first is the skin. So skin of the scalp is very hairy, and it has high number of sweat and sebaceous glands. So as there are high number of sweat and sebaceous glands, so there are very high chances of getting sebaceous cyst in the scalp region because of the more number of sebaceous glands. Then below that, below the skin, we have superficial fascia with blood vessels. Okay, so more fibrous. So these fascias are fibrous and dense in the center, and it has also so many blood vessels in it, right? Then we have connective tissue. These, as I already told you, these are dense fibrous connective tissue which are firmly bind to the skin to underline occipitofrontalis aponeurosis. So these connective tissue, what does it connect? It connects the upper layer. This connects the skin and superficial fascia to the aponeurosis. It tightly connects. As I told you, these 3 layers are tightly connected to each other. So these connections are made by this connective tissue. Okay, it is responsible for adhering skin with the connective tissue and connective tissue with the aponeurosis, right? And also in the aponeurosis, that layer we have occipitofrontalis muscle, which we'll study in this diagram. So third is the aponeurosis, which is formed by occipitofrontalis muscle, right? So what is this muscle? Muscle is divided into 4 different types. So like it has 2 bellies. As you can see in this diagram, this is the frontal belly and this is the occipital belly. Okay, there are 2 frontal belly and 2 occipital bellies. Okay, and in between this whole area is the aponeurosis. This aponeurosis is epicranial aponeurosis, right? What is basically the aponeurosis? Aponeurosis is basically a flattened tendon, which is the extension of any flat muscles. So this aponeurosis is basically the extension of the muscle, or we can say it is a tendon which helps to connect muscle with the underlying bone, right? The main part of aponeurosis, the main part is made by aponeurosis. Hence, this layer is known as aponeurotic layer. Then we have loose areolar tissue. It extends from front of eyelids to posterior to highest and superior nuchal line. So loose areolar tissue extend from, it has same extension as that was for skull. It extends from here, superior orbital area, to superior nuchal line and highest nuchal line. So here. So loose areolar tissue extend from here, here to this side, right? Now we have and it has no bony attachment. This is the most important point. You will see some of the clinical relations with respect to this having no bony attachment. Then we have the very important thing, again very important thing, is emissary veins. So as loose areolar tissue extends from eyelids to the superior nuchal line because of the frontalis muscle, and it gives way to emissary veins which connect extracranial vein to the intracranial venous sinuses. Okay, so these are the valveless veins. So these veins, what it does, these veins are present in the loose areolar tissue, and this vein is responsible for connecting the extracranial vein to the intracranial veins. Okay, and we'll also study the clinical significance of this vein later. Then we have pericranium. Pericranium is basically loosely attached to the bone surface and firmly attached to the sutures. Pericranium is basically periosteum only. It is the outermost covering of the bone, right? And it is loosely connected to the bone surface. And now we have the nerve supply of the scalp. So we need to remember this by heart. So there are 10 nerves in the scalp on each side. So basically there are 20 nerves in the scalp total. So these 10 nerves are divided into 8 and 2. 8 are the sensory nerves and 2 are the motor nerves. So these sensory nerves are 4 in front of the auricle and 4 nerves behind the auricle. So we have divided this sensory nerve, this nerve supply into 2 parts, and further sensory nerve is divided into 2 parts, anterior to the auricle and posterior to the auricle. So nerves coming anterior to the auricle are the trigeminal nerve, and the nerve behind the auricle are C2, C3 nerve. So C2, C3 nerve. So on the anterior of the auricle we have supratrochlear, supraorbital, zygomatic temporal and auriculotemporal. See, this is here trochlear. The word trochlear means if there is any kind of turning. So this vein is something turning in the front, which we cannot see in this image, but yeah, it is turning. So therefore it is named as supratrochlear. And this nerve is known as supraorbital because it is present in above the orbits, right? And here the temporal bone is present, temporal, and in front zygomatic bone is present. Therefore it is known as zygomatico-temporal, and this one is auriculotemporal because it is near the auricles. So on the posterior side of the auricle we have greater auricle, lesser occipital, greater occipital and third occipital. Greater auricular, lesser occipital, greater occipital and third occipital. So greater auricular nerve we have C3 and C2, lesser occipital we have C2, and greater occipital we have C2, and third occipital we have C3. So first we have C2, C3, then we have C2, C2, and then again C3, right? So we studied about the nerve supply. Now we'll study about the we studied about the sensory nerves. Now we'll study the motor nerve. So motor nerves are those nerves which supplies nerve impulse from CNS or the PNS to the sensory organs. So we have four motor nerves, so 2 on each side. So this is the temporal branch of, so these are facial nerves. Okay, so these are facial nerves. First is the temporal branch. So this side we have temporal bone. So therefore this is the temporal branch of facial nerve. And this side, this is the posterior side of the auricle. So this is posterior auricular branch of facial nerve. So motor nerves, we have two kind of motor nerve. First is the temporal branch of facial nerve, and second is the posterior auricular branch of facial nerve. Now nerve supply is done. We'll study the atrial supply. So atrial supply, so in the scalp, we have abundance of atrial supply, or the blood supply. We have rich blood supply. So on each side, 5 arteries are supplied. So 3 on the front of the auricle and 2 behind the auricle. So on the front of the auricle, we have 3 arteries. These are supratrochlear artery, orbital artery. Then we have superficial temporal artery. So these three arteries are in the front of auricle. Now behind the auricle, we have, behind, that means posterior auricular artery and occipital artery. So superficial temporal artery, posterior auricular artery and occipital artery, these 3 arteries are supplied by external carotid artery, and supratrochlear artery and supraorbital artery are supplied by ophthalmic artery. So these 2 arteries are supplied by ophthalmic artery, and the rest 3 arteries are supplied by external carotid artery. Right? So in the front we have, so I have already written, these 2 are supplied by ophthalmic artery. Ophthalmic artery is a branch of internal carotid artery, and superficial temporal artery, posterior auricular artery and occipital artery is a branch of external carotid artery. Ophthalmic artery is a branch of internal carotid, and superficial temporal, all these 3 are branch of external carotid. Right? Okay. Now we will study about the venous supply of our scalp. So we have 2 main veins in this, on the lower part of the scalp. First is the internal jugular vein, and second is the external jugular vein. So here we have to remember it. There is no other option. Just along with me, try to remember or memorize the whole pathway. Right? So there are 2 veins. As we studied in the artery, we studied supratrochlear artery and supraorbital artery. In the same way, we have 2 veins, supratrochlear vein and supraorbital vein. These veins are forming angular vein on the, where are they forming the angular vein? On the median angle of the eye. So let's suppose eye is present here, right? So on the medial angle of eye, these are forming the angular vein. Then on further extension, it is forming the facial vein. Angular vein is continuing as facial vein. Then facial vein is giving one branch as deep facial vein, and it is continuing as common facial vein. Right? And then it is draining into internal jugular vein. Now see what's happening on the auricular side, or the little posterior side of the scalp. So there are maxillary vein and superficial temporal vein. So we had 3 arteries: supratrochlear, supraorbital and superficial temporal artery. Right? So with the same, you can also remember the names of vein. So supratrochlear, supraorbital on the front, and superficial temporal vein on the behind. But superficial temporal artery was in the front. Right? So maxillary vein along with the superficial temporal vein are combining to form retromandibular vein. Okay, these are combining to form retromandibular vein, and retromandibular vein along with the, these are like dividing into anterior branch and posterior division. Okay, so maxillary vein, superficial temporal vein are forming retromandibular vein. Retromandibular vein are dividing into anterior branch and posterior branch, and posterior division is connecting with posterior auricular vein and draining into external jugular vein. Again, try to remember with me. So on the anterior side, in front of the eyes, we have supratrochlear vein, supraorbital vein forming the angular vein. It is continuing as facial vein. Then facial vein is giving branch as deep facial vein, which is again continuing as common facial veins, and it is draining in internal jugular vein. Right. Then we have maxillary vein, then superior temporal vein. It is forming retromandibular vein. Retromandibular vein is giving two branches, anterior division and posterior division. Posterior division is combining with posterior auricular vein, okay, and it is draining into external jugular vein. These veins communicates with intracranial venous sinuses through emissary veins. So these veins are present in the, like, on the outer side. These veins are present on the outer side and the epicranial, and these are interacting with intracranial venous sinuses through the emissary veins. Emissary veins are valveless veins, and these veins are present in different sizes, number in different patients, right? In different individuals. And there are two sets of emissary veins on the scalp. First is the parietal emissary veins, and second is the mastoid emissary veins. How are they dividing into two types? On the basis of the foramen. Parietal foramen, which like veins passes through this foramen, parietal foramen, and it is communicating with superior sagittal sinuses. So sinuses are present below the cranium. So this parietal vein is passing through the parietal foramen and communicating with superior sagittal sinuses. Then mastoid, this mastoid vein are passing through mastoid foramen. Mastoid foramen is kind of present in the temporal bone as an extension of the temporal bone. So this is communicating with the sigmoid sinuses. So lymphatic drainage. So we have lymphatic drainage from two sides. First is the anterior and then the posterior. So I'll show you an image in determining the lymphatic drainage of scalp. Right. So from this picture you can see the lymphatic drainage in the posterior side and in the anterior side. So posterior side, it is just behind the auricle. So this is the temporal vein, temporal bone, okay, and this extension is known as the mastoid part of temporal bone. So here one lymph node behind your auricle are present. So this is mastoid nodes, and one pair with number of nodes are present here in the occipital bone. So this is known as near the occipital bone. So this is known as occipital nodes. And on the front side we have pre-auricular and parotid nodes. Okay, so here we have parotid nodes, right? So on the anterior, scalp drains into parotid lymph nodes on the surface of parotid gland. So here parotid gland is present, and posterior scalp drain into mastoid and occipital lymph node, right? Mastoid and occipital. Just remember this. Now we have the most important part of the scalp. Like, scalp is important because of its clinical anatomy. So on the skin, we are studying the clinical anatomy layer-wise. So on the skin, we have sebaceous cysts are present. Might be present because of the high number of sebaceous glands. So these cysts develops, and inside those cysts we have pus and all these things. Okay. And then there is surgical layers of scalp. As I've told you earlier, like SCA. These three layers are like very adherent, tightly adherent to each other because of this connective tissue which is connecting the skin and the aponeurosis with each other, and these are kind of inseparable with each other, and these are known as the surgical layers of scalp. And another name of these three layers is known as scalp proper. So avulsion, when hair is caught in the machinery, so for some women when it caught in the machinery, then all these three of these layers are like emerges out. Okay. Then we have black eye. So blood and fluid connected in layers of loose areolar tissue. Okay, because it has the potential spaces and the good amount of nerves like blood supply in these layers. So due to potential space, there is swelling on scalp. So blood do not pass. A blood cannot pass through the posterior side and the lateral side because of the bony attachment. But the bony attachment is absent in the anterior side of the scalp. Therefore, what happened? The blood do not passes to the occipital and temporal region because of the bony attachment of occipitofrontalis muscle. Then, but occipital frontalis muscle do not attachment on the anterior side. Therefore, fluid passes to eyes and root of the nose, and which causing hematoma. Hematoma is basically blood cause after any kind of head injury and operation. When there is collection of fluid, it causes black eye. Okay. Then we have dangerous area. First we have surgical area. Surgical areas with respect to SCA level. Then dangerous area, what happens? Dangerous area is formed because of the emissary veins. So layers of loose connective tissue have pus and blood collects on the layers of loose connective tissue, loose areolar tissue, and infections travels from extracranial vein to intracranial venous sinuses through this emissary vein, because emissary veins are enclosed in loose areolar tissue, which can lead to thrombosis and fatal. So emissary veins, in this we can have thrombosis, we can have infection due to these emissary veins, we can even have bacterial infection through these veins, and it can cause, and when it has thrombosis or the blood clot due to these emissary veins, it can also lead to fatal. Then we have profuse scalp bleeding. So there is heavy blood supply. What happened whenever there is cut in the blood vessels? So these are the fibrous septas are connected with the atrial wall. So if there is cut in the blood vessels, small laceration can lead to heavy blood loss. Why? Because whenever there is cut in the normal blood vessels, there is retraction of blood vessels, and blood vessels retracts this way and forms the clot. But what happens in this, the layers of scalp? We have fascia connected to it and fibrous septa connected to it, and it is connected very tightly. So whenever there is a cut, it is not able to retract itself. It's not able to contract itself because of the connections, and therefore we have to apply local pressure. Have you seen patients wearing, if there is head injury, they are wearing this kind of a white bandage all over their head, okay, covering all the parts of the head. So this is providing the local pressure from all the sides. And no necrosis in large avulse flap of the scalp with narrow pedicle. So sometimes what happens, due to excessive blood, there is some injury, so there is blood loss and there is form of narrow pedicle. Okay, like all these three layers, this just avulsed out, and it can cause narrow pedicle, okay, flap of scalp. So instead of cutting those layers out, what surgeon do, they just cover this head and stitch it. Because what happened, if we take this layer out, we have to take the complete layer out, as it is firmly adherent to each other. So rich blood supply is there, so heal scalp wounds, so they are retained, and it should be sutured in place. So we should stitch that part. I'm sorry. So this technique is basically also, it helps in plastic surgery of face. So I hope you got it. Thank you so much.